So I think we'll get started. We've got an amazing group of people to speak to you today. I'm Deanna Dahl-Grove. I'm a peds emergency medicine physician in Rainbow Babies and Children's in Cleveland, Ohio. We've got Brent Kaziny. He's a pediatric emergency medicine physician at Texas Children's. We've got Michelle Moegling is a project manager and a nurse at Rainbow Babies and Children's in Cleveland, Ohio, works on the ASPR Eastern Great Lakes Pediatric Center of Excellence grant with me also. We've got Sarita Chung is a pediatric emergency medicine physician at Boston Children's Hospital. Meredith Rodriguez is our astute project manager for the disaster domain on the EIIC, and we couldn't do anything without all of her great technology skills and everything. And then contributions both from Laura Aird and for Heather Fitzpatrick at the American Academy of Pediatrics, and we appreciate their input into this presentation. So we really wanted to cover in this sort of how we can get state partnership programs involved in regional drills and disasters so that you can kind of get an idea of what we've been doing. Over the past year, we've learned a lot on the virtual platform, and we really want to give you some practical tools. So next slide. So why do we do disasters in exercise? The why, the what, and the who. Next slide. So we do these exercises because they really are a component of the preparedness cycle. They really, exercise sort of help us go through, help us figure out what is going on in our emergency management plan, whether we're at the federal level, public health, state, local, schools can do these, all sorts of participants can be part of this whole activity. And it really becomes much larger when you involve more participants across the board is obvious, but I think it's really important to understand that these can be done on multiple different scales. And they really help you to go through and identify where your weakest points are in case you have a real event. And this allows you to go through an improvement cycle. So next slide. So while our polling questions aren't working, if you could please put into the chat, we'd love to just sort of have you answer these questions and just sort of interested in what's going on for you. If whether or not you've participated in an exercise or helped with an exercise. And you can also answer, if you would like, what are some of the challenges you've had in conducting an exercise and what are some of the successes you've had? I think it would just be interesting for us to see those if you're able to put that in the chat. Pat Frost has participated. Yes, Pat, thank you so much. Absolutely. We've had other people participating in them. I see some challenges are connecting with the clinical frontline, objectives and mindset of emergency management. And it can be very different, yes. That's why a diverse planning group can be really helpful. I see some more people with some yeses and haven't helped plan. So hopefully this will help you walk away with some tools to understand how that works. I've got another comment, expertise from Oregon Health, security, preparedness, and response exercises, but haven't participated. Yeah, getting the right people at the table is really important. Sometimes it just takes some practice as to who you might actually learn in your improvement cycle, who was missing. So that can be very interesting. We're going to see if we can propose some prospects for this overwhelming, if there's just one hospital and not sharing resources. We're going to see if we can answer some of those challenges. Yes, getting leadership involved is really important, but hopefully after the COVID experiment that we are currently in, people will have a better idea. And then aligning the drills with training programs. Oh yeah, that's really at academic medical centers, we definitely run into that. You can keep putting things in the chat, but I'm going to move on to the next slide. So what kind of disaster exercises are we talking about? So this can be something where you decide you're going to just test a whole plan. You can test a new protocol, you can test a new procedure. So it's just a way to sort of learn how to practice new skills. It might be inputting patients into a new tracking system for registration. It might be a new patient triage system that you've decided to roll out maybe in your regional area. So you really can keep it very focused, or it can be very broad, and it could involve, going through and triaging in the field, to doing a hazmat setup, to, actually placing patients into the hospital, all sorts of complexity to the drill. And it really takes a lot more preparation, obviously, for complex drills. And it takes a lot more partners at the table. It takes months of planning. You can also use it for training on new equipment, i.e. if you had new radio equipment. At our hospital, we've early on, probably back maybe 12, 15 years ago, we actually set up drills to go on a monthly basis to use the radio equipment for communication for like a half hour, just to call up admissions and things like that, so that different shifts would get used to using the radio equipment. You could use it for doing, new devices for evacuating patients from the hospital, new hazmat equipment, things like that, and new hazmat teams. So it's just a way to sort of assess and improve ways for different stakeholders to be involved. Next slide. So what are the different types of exercises?
Deanna, do you want me to take it from here?
Yeah, that's great, Sarita. Go for it.
We're a pretty informal group, so I just wanted to add that if you have any questions at all, please add it in the chat, and we're hoping to have some time afterwards to really talk. Or so please, we have some slides set, but if there's things or burning questions, we'd rather answer your needs and within our slide deck. So when we talk about the type of exercises, there's many types. There is the tabletop, where it's more that you are trying to start out a new process or test a new process. So you bring key partners into a room or even into a virtual setting where you kind of talk about the various scenarios and how they would play out. A functional drill is similar to a tabletop, but now you're actually activating systems, you're actually testing that, and it may involve different places where that each center is being activated, or each part. So like emergency room may be participating in the functional drill. If you're sending patients up into the ICU or to the ORs, then different parts of the departments will play. A simulation is, and that's getting more and more in the disaster field. I think understanding that functional drills are very difficult and very expensive. How can we simulate to get the same experience and also provide the same teaching? So really, in our emergency room, we actually recently did a mass casualty sim where we simmed like not the initial drill, but the next 15 minutes. So you had 4 critical care patients, you had many urgent patients, many green patients, and how would our emergency room staff interact in that situation? And so it really helped bring more awareness to our staff of the scarcity of resources in a mass casualty, and just really understanding the how do we get more resources to the ED. And lastly is a mini exercise, or some people call it a huddle, where there is a short exercise with few participants and you're testing one objective. One way we do this in our emergency room is that we, every month we do a co-triage or our mass casualty drill, where we just spend a short amount of time with our charge nurse and our attendings and say, okay, a mass casualty scenario is coming. What are the first steps you need to do? And that allows them to kind of think on the ED to say, okay, what are the next steps? What do I think about as far as staff, space, stuff, and structure? Next slide. So just interested, for those of you who had said yes, what type of exercises have you participated in? Next question, did you include pediatric patients? And then what types of scenarios have you participated in? And as we're receiving this, I think Pat has also added in some things in the chat that are very useful, thinking about pediatric decon, pediatric surge, And I think the last one is actually really interesting and it's gaining momentum is how do we decompress a pediatric regional center if a pediatric tertiary care center doesn't needs to be evacuated. How do we spread pediatric patients across the region? So I think we'll continue just because I'd love to hear about the discussions. The AAB topical collection, so great. I see here that we've, yes to both plane crash hazmat events and including pediatric patients, so but more tabletops. So that's great. So the AAP topical collection, there's a topical disaster collection, has a whole section on exercises. And really this is just one of the tables we pulled out just to give you a sense of how long things can last and actually also what is the planning time. So for instance, if you go to workshops, those workshop can take 3 to 8 hours. The planning time usually takes about a month. There's usually a small group planning team, and then you define the objectives. Sometimes this is accompanied by a PowerPoint, a moderator, and a facilitator, and then also a participant feedback form. I think what's important is whenever you have a drill or a workshop or exercise is that you really want to think about your objectives beforehand, like what really do you want to accomplish and how do you measure it? And what's helpful actually is by joint commission, all hospitals have to do drills, right? So as a state partnership, it's really helpful to a director is if you know hospitals have to do drills is really to see how you can help them encourage pediatric participation or have them think about kids in their drills. Next slide. And then I think now we're really into the era of virtual exercises. And so really the advantage of virtual exercises is that we used to have to bring everybody all in one place, right? So if you wanted to do, I'm from New England, a New England regional kind of drill, we would try to choose a central location and everybody would go to it. This allows more flexibility, but also more, makes it more realistic because if there is something that happens in New England, you would not be traveling to a place, a central place. You would be working out of your own command center in your own state. And so it really helps play out what would happen. This is a slide of a CDC drill that we did with FEMA Region 7. It was Iowa, Missouri, Nebraska, and Kansas, where we did a smallpox outbreak. And believe it or not, this was actually 4 or 5 years ago when we thought this was so cool because, you know, we were doing it on Zoom. Now it's probably not, you know, it's great, but it's not as novel. And it was really pulling the teams together. You can see on the slide, there's just different teams in different command centers and then giving them the scenario and asking them how they would work it out in their state and how they would work interstate and intrastate and work in the region. Next slide. And so when we think about what are the critical areas of focus that we can think about in our drills? So is it communication? You know, is it really providing the key communication and to who and to where? Is it how do we provide patient care in a disaster? Thinking about additional spaces, is there additional patient care spaces? For those of us who've been around for a while, the H1N1 pandemic affected mostly pediatric patients. And so we had to think about alternate spaces to safely care for patients. I think Brent Kaziny this morning talked about the winter storm and talking about patients with special healthcare needs who they needed to augment additional spaces. You know, staff support, what kind of staff do you need? And really thinking about it in a multidisciplinary way. It doesn't have to just be physicians and nurses. It really is support staff. So if you have in your in your hospital, or if you're doing drills, if you want to have availability of child life, social services, I think those are important adjunct members to think about as you think about taking care of kids in disasters. Most importantly, safety and security. How do we make sure that the kids are safe in terms of family reunification? How do we make sure that a child is not being taken away or not being reunited with the wrong family? Resource and assets, like if we needed to transport kids through large distances, what kind of transportation mechanisms would we use? What shelters are available for children? Supply chain is a big issue, and we've seen that in the past year with the pandemic. Like supplies are very limited, and so making sure that hospitals have the supplies that they need for kids, and then really thinking about leadership and leadership structure during the disaster. Next slide. So as far as planning and logistics, thinking about planning, this is my favorite quote from President Eisenhower: "The plan is nothing, but planning is really everything." So thinking about, when you think about your plan, you have to have, you want to think about the exercise plan, the participants, how you collect the data, how you communicate, and how you identify staff moderators. Be very clear in the goals and objectives. And really, in order to prepare your participants, you want to share the materials ahead of time. Next slide. And this again is from also the American Academy of Pediatrics, but they have a pediatric tabletop exercise toolkit on how to prepare for disasters. And it takes you step by step, such as establishing the planning team, determining the date, scheduling meetings. And I think as a state partnership director, or all those who are pediatric advocates, it's really just being at the table, right? It's just trying to see who's doing drills in your region and how we can be at the table, and then how we can say, well, have you thought about kids? What, in this disaster scenario, where are the kids going? Or have you thought about the family? How are we going to keep the family intact? Next slide. So I'm going to turn it back over to Deanna to talk about the great work that they've done at the Asper Eagle as far as exercises. Thank you.
Yeah, so I'm just going to mention some of the exercises that we had over as a result of our Pediatric Center of Excellence that was awarded from the Asper back in 2019. So it was really quite interesting. We had planned this big sort of culmination exercise that was going to happen in 2020. But then halfway through our grant period, we obviously had the pandemic approach, and we had to really learn how to shift gears. So this is where the sort of experience with the AAP and participating in virtual drills really became quite an event to just sort of like move forward. And so we started planning our first virtual drill, which ended up being the Darkest Winter, which actually is a pediatric disaster and surge drill about COVID, or a similar kind of measure where the pediatric hospitals are overwhelmed, and what would you do? So this was really a fantastic way for all of the partners in our two state region, both Michigan and Ohio, to actually be involved in the whole entire drill. There were our state partners were involved. We actually had an educational session as sort of part of it, just to sort of work on, what that would look like. And we got a lot of really great feedback. We have an excellent virtual exercise planner that we just give kudos to all the time. So then we, as a result of our work with the EIIC in collaboration with our quality initiative, we actually did a pediatric disaster quality collaborative with about 31 other hospitals. And as a result of that collaborative, there were 9 modules in there, but one of them was on family reunification toward the end. There really was a desire among the participants to actually have more of a sort of drill on reunification. So we created a virtual reunification drill, which we held back in April. And I think the idea is that each of the hospitals in and of themselves would sort of decide, how they would approach the reunification questions that were sort of put through in the simulation kind of workspace and sort of answer those, share answers among each other so that we could understand how their processes might work and understand where others were and so on. So the virtual platform really allowed us to sort of group participants. It allowed participants to sort of have their own discussions among themselves in their incident command centers, but then actually come back and actually share their knowledge. So it's almost it's a drill, but also a learning session for other participants at the same time. It can be very helpful. And then our last drill that we had for the Eastern Great Lakes was a telehealth advancing capabilities virtual exercise. And this was a little bit different in that each of the institutions, we had, I think, in the neighborhood of 8 or 9 different demonstration projects on different ways that telehealth could be used in a disaster kind of platform, from doing an MCI triage with a community hospital to a pediatric hospital and deciding, which patients should be transported, to another component that was demonstrated. This one was just-in-time training of a nurse at a community hospital with a nurse at a pediatric hospital on how to do certain kinds of medication drips and things like that, because a patient couldn't be transported because of severe weather. There was a virtual ICU demonstration. So really, all of these exercises are actually up on the EIIC website, and I would encourage you to take a look at these. So there is a manual about how to do it, and there's an after action reports, and I think that could be very helpful for you. So next slide. These are more of the toolkits that are actually involved on the AAP website in addition. So you can see the source of these is different states partnership, but you see you got lots of tornadoes, you've got bus accidents, and it sort of talks about what their scenario is, the type, the length of the drill, and then the source of the actual drill. Next slide. The CDC also has some toolkits that can be really helpful for sort of planning a little bit more on a generalized scale. But again, things that, you might find sort of useful as you're sort of starting to, build out what your drills might actually look like, and just sort of getting started in this. Or if you're just sort of a participant, making sure that there's, ways of incorporating some of this stuff in for children. And next slide. So the best practices for success for sort of defining your drill when you're getting ready for your preparation is to actually, who is your audience going to be? So, if you've really decided that your audience is just going to be, is it going to be a public health? Is it going to be just at your hospital? Is it just going to be your getting patients maybe from your ED to your surgical suite? Or is it going to be just one department? It's going to be really important to think about that. Or if it's going to be a statewide drill, maybe it's going to be all of your, some community hospitals that have some pediatric assets, and maybe they're going to be offloading one of the children's hospitals that's in your state or region, and figuring out how to do that with an evacuation plan. So it would involve many more participants at that point. Then you'd have to, do your recruitment plan based on who your audience is going to be.
Mira eso.
Oh, sorry.
El cielo.
Oh, sorry.
El cielo.
Oh, somebody's got their microphone on. Then, sort of based on, who's participating, then set the expectations, especially if you're going to do it on a virtual platform. And I like the virtual platform from the standpoint that it allows people to participate in multiple geographic areas. You can actually share real-time experiences. They don't have to travel. And I mean, if it's a localized, if it's a local drill and you don't want to get together, it is kind of nice when you can meet face-to-face with local participants. But we've discovered that, reaching across state lines and involving state partners, it was actually very beneficial to have the virtual platform. We want to, whenever we held our virtual drills, we were very clear about our timelines and really stayed consistent with those so that everybody understood what their expectations were, and also estimating what their time commitments would be for the entire drill. Next slide. All right, so sort of just things to think about for virtual exercises. Remember that The host site wants to make sure you have IT involved. You really want an IT crew in the background as well as audiovisual support so that you, as perhaps the exercise planner, can really just concentrate on the details of like running the chats and helping with the organization. I know that our host site has had a really incredible IT support team in the background that really helped things go well. And it's really important to have that done and down. You can use group chats, like you can either do GroupMe or WhatsApp to communicate in the background with some of the perhaps moderators that you might be having. And things like that. And we really tried to keep the components of our drill sort of well-defined. So, we wanted, 15, 20 minutes to go into discussion. So although kind of arbitrary and a little bit short, they actually, I think, encourage people to sort of move along in the discussion, as well as having breaks. Even though you're on virtual platforms, you want to make sure that you put breaks in for people to be able to get up and move around. Next slide. So next, I'm going to turn this over for Brent Kaziny to give us a little bit more details about other types of things to think about for exercise.
Hey, everybody. And I apologize. They just started doing some construction above my office. So if the background noise gets unbearable, let me know. This is just a screenshot from a cyber incident drill that we did virtually at Texas Children's. And you can see the injects are presented. We had executive leadership participating, and it really worked well for this platform. So it's definitely something you can do and something you can pull off. And I think it works great, especially in what we're dealing with now, but even for the future, as previous speakers had mentioned, being able to reach people that aren't necessarily geographically close to you. Next slide. I think one of the challenges in disaster medicine in general is keeping an aim towards quality improvement and making sure that we're measuring the success and the challenges that we faced when we do these sort of drills. It gives us the opportunity to test something that we know has a low likelihood of occurring in our community, but would be a high consequence event. So keeping in mind the PDSA cycle to plan what you want to measure, do the exercise, study the results, and then act on the information. So developing an after action report that's going to develop tangible results from that exercise, and then doing a similar exercise maybe the following year in 2 years to show the success that you've had. Next slide. One great training resource for those of you that don't know about it is the Pediatric Disaster Response and Emergency Preparedness course put on by TEACS, Texas A&M Engineering and Extension Services. This is a free-to-use course that's sponsored by FEMA. It's an in-person 2-day, 18-hour course that gets put on across the country. And if you haven't had the opportunity to take this course, I highly recommend it. They do have an exercise component to it, but also give a lot of ideas as far as systems that you could test if you were going to get involved in drills in your location. And as Pat mentioned in the chat, they recently updated the curriculum, so it's great. Next slide. So one of the things that we've already seen mentioned in the chat, and I think is very important to continue to mention, is really what we're trying to do here, and in particular for state partnership grantees, is recognize that you hold this particular specific role as the voice of children in your communities. And so getting engaged in drills that may be occurring on a regional or statewide level is important. And reaching out to those people that would likely be putting those drills on is important. And here's a list of some possibilities or people to reach out to. Those that are involved in your hospital preparedness program, your public health emergency preparedness grantees, as well as your state's Office of Preparedness or Emergency Management. They are likely conducting drills on some degree of regularity. And these may not be hospital-specific drills, but regional drills that really engage public health. And having, again, that voice of a state partnership grantee sitting at the table as the voice of children is extremely important. Next slide. And that ties into really promoting pediatrics at a state level, not just recognizing our public health partners, but who else in your state is really pushing this agenda, trying to include children in the drills that are being conducted on community hospitals or on regional level. So really trying to see who's already meeting, who's already working on this. We don't want to overburden the grantees with additional work, but there are people working on this pretty much across the country. And so trying to find those people and pair with them potentially be a conduit for resources that have been developed by the EIC and other sources could be terrific, including those mentioned earlier in the talk related to the AAP's exercise guide. So find out who's meeting about this, talk to your AAP's chapter, other pediatric advocates that are in your region, and figure out who's doing these exercises. Do you have a local pediatric disaster coalition? Do you have a local disaster coalition that's doing exercises? Are there hospitals in your region that you know are well resourced and do routine exercises and pair with them and see who's doing this sort of work? So those are all, I think, great, healthcare coalitions being a great starting point, as well as some of these other targeted, specific to pediatric resources that might be able to promote the engagement and involvement of pediatrics in all disasters that are happening in your area. Next slide. So again, I think what we really need to think about are kind of what are the scenarios and issues that we think probably are high yield scenarios to work on and drill towards effectiveness in response. And some of the things that we've heard over and over again from people that have participated in past exercises that we've conducted, as well as our quality improvement project and other things, is that there's definitely a need and desire for more information related to treating children who arrive without a caregiver or a parent. So obviously this provides a lot of complexities and challenges. You need additional staff to care for that child and support that child, to keep them safe until they're reunited, leading to the next bullet, which is really identifying those children and reuniting them with their families. So some sort of family reunification drill, encourage participation from local school districts and daycares that take care of these children every day. Other things that we think are likely high yield as potential avenues for drilling would be looking at pediatric triage, as we know that routine triage can be a challenge for kind of resource limited or critical access hospitals, community hospitals that see a large number of children but aren't really pediatric centers. And in that same vein, looking at pediatric size equipment and their use of it. And of course, something that's been really highlighted during this current disaster is the need for mental health and additional efforts in the mental health space specific for pediatric patients. So that's just kind of a smattering of examples of possible topics to discuss and to kind of try to, if not specific drills devoted solely to that, try to tease that into pre-existing drills to get kind of to the oomph and the real challenges that present with when children are involved. Next slide. And finally, if I haven't hammered through this enough, I think really trying to figure out who in your community is not just pushing the agenda for children, but pushing the agenda for disaster preparedness, and talk about what areas in your community may be areas of interest to target specific for disaster planning. So, we talk a lot about working with public health, working with pediatricians in your region, but it's also working with your community as a whole. And what resources can you as a state partnership grantee push out to your community, including neighborhoods, schools, places of worship, et cetera, including your functional access need families, and that family input, as Sarita mentioned in the chat, is also very important. And then along that vein, not just looking at the community, but recognizing again that many of our healthcare systems are not pediatric centric or focused specifically on the care of children, and identifying who they may have in the region that are going to be great assets to you in pushing this agenda by identifying their pediatric emergency care coordinators. Next slide. And with that, I'm going to pass it off to Michelle, who's going to work through PECs in the planning. Thank you very much.
So how can you utilize your PEC in planning for disaster or readiness? They can help you ensure the availability of any essential pediatric supplies and equipment, really assure staff are adequately trained in the use of equipment and how to utilize it on children if you're a community facility or a rural area, out in a rural area with EMS. Really making sure that they know how to resuscitate an infant or child. What equipment do they have? Where is it located? And how do they use it? And doing that frequently. So it's not that one-off when you have a resuscitation. Assure that there are ED policies and procedures that consider the needs of children of all ages. facilitate the integration of pediatric needs in our hospital disaster or emergency preparedness plans, and promoting the inclusion of pediatric patients when you're working and doing drills. We do have a couple of resources here. The National Pediatric Readiness Project and Pediatric Readiness Toolkit will help with like some of the supplies and equipment that are needed, and even some of the policies to consider, making sure that pediatrics is part of that. Next slide. How can the PEC play a role in disaster planning? Like we talked about, having pediatric considerations, making sure they're incorporated into the hazard vulnerability analysis. So are you considering those when you're doing your yearly HVA assessment? Assuring that disaster drills include pediatric patients and not just teenagers, but children of all ages. They can serve as a liaison for your pediatric patients' concerns on hospital committees, looking at traumas that are coming in, or medical patients, or disasters that have happened in your community. They can help assure pediatric considerations and priorities included in all staff disaster education and training, and also including pre-hospital. There are many pre-hospital places that also have a PEC, and they can collaborate with them to ensure that everybody is trained. They can really assist with development and review of the hospital disaster policies, really making sure that you guys are meeting the needs of pediatrics. Looking, do we have an area where you're going to keep those pediatric patients that are stable or ready to go home or just waiting for families, and how are you going to keep them safe? Promote community disaster preparedness that also includes children, working with families that have children with special health care needs, and then collaborate with disaster managers as well. We also encourage the recruitment of hospital emergency managers to help define some of these responsibilities. So working with the ED or the EMS to help them define some of these responsibilities and how they can assist. Next slide. So by failing to prepare, you're preparing to fail. From Benjamin Franklin. Thank you guys for listening to our presentation. We want to open it for any questions or thoughts. And that was great, Sarita. Yeah, and making sure that you're including your fan member and getting really family input on these policies. Thank you for sharing that, Pat. That came out of our first ever pediatric hazard vulnerability tool, actually came out of our ASPR grant this past year.
Hi, this is Sarita. I would be interested, I'm just looking at the comments about just hearing people's experiences. So if Brian Richardson is still on, I'd love to hear a little bit about using a scenario and thinking about stress metacognition and decision-making. I think we are very stressed. So if you're available, please, I'm totally cold calling people, so I apologize. But I think the more we do this and the more we insert ourselves into disaster drills, people will realize how they may have not met the needs for children. And I can give you an example of one of our disaster drills. I would say a key marker of disaster drills is if you, and if you include kids, is if you lose a kid. So we did a disaster drill at our facility, at our hospital, where we did a family unification drill, and all the kids were supposed to line up in the room, and we're going to take their pictures, and then they were going to play in the room. Some kid decided not to be in the line and decided to just start playing in the room, but we didn't have any record of that patient, of that child. And so when the parent was trying to look for the child, she knew the child was in our room. She had dropped him off, but we actually didn't have any record of her child in that room. And that caused a lot of anxiety, just because it was like, what do you mean you lost my child? And so I think really doing these drills and actually having children participate shows you where the cracks are, because the kids are not going to stay still, right? They're going to want to explore. And so if you don't have eyes on them, or if you don't create a safety network where there's people constantly looking at them, whether it's creating a pediatric safe room or something like that, then they'll wander off. And so I think that's important to really look at where there could be gaps in your drill.
And Sarita, I would say one of the things that I think is important to highlight related to what you were saying is, when we talk about children, we're not talking about like 17-year-olds, because we hear oftentimes hospitals do disaster drills, and I'm guilty of this as well. And we use high school students. But if you really want to test your systems, in particular related to reunification, other things, using very young children pose tons of additional challenges because they just need a lot more, supervision and people to keep them safe. Because like Sarita said, they'll wander off. Those of us that have small kids know they like to get into trouble. So
and thinking about, I'm sorry. Also thinking about young children or infants, how would you decon them if you had to do that? Do you have the appropriate stuff to do that?
And Brian, I don't know if you are available to share, if you want to unmute yourself.
I'm here, if you can hear me.
Yes.
Great. So I'm sorry. The question is what we did with our exercise. It was really pretty straightforward. We just took charge nurses, gave them brought them together, did a little bit of work on sort of your observation, orientation, decision making, and acting, and then reevaluating sort of that OODA loop of figuring out how we make decisions, what impacts that, what affects that from day to day, staffing. Basically we looked at the space. Staff, supplies, systems of care, and standards of care, given the current situation, where they're at, their past experiences, any intrinsic bias, anything that they had, coming into that, and kind of pulled apart how they think about these situations. And then we gave them a really brief scenario and had them look at the current situation and, in about a 15-minute time frame, and had them just pull apart and come up with some, what is your decision making? What did you need to do? And how it relates to our policies and procedures, and where would you go with that? So that's all we did.
No, thanks. I think that's great. I think, did you find themes that came up, or like common gaps that were made consistently?
Yeah, thinking outside of their immediate moment was really difficult, and looking ahead, as we know, a couple steps ahead and down the lines, and impacts on beyond your immediate area, inpatient, blood bank, surgical, and we think about it, but not to the extent that we wanted them to really go down the pathway. So there were some gaps there. So it was very interesting, and I think they learned a lot, and we had a good time. It was very quick and down and dirty, and in the department itself. So.
Brent, I think you mentioned, I think that when you're thinking about drills, we all can talk about, and we'll get into a little bit more of this, I think, on tomorrow's presentation, but it's the small drills, kind of like Brian, that you just sort of described. It's sort of sitting down and just talking through a really small one. It's a new process, how to make that happen. And I think it really sort of empowers people to do that. So, if it's just sitting down with, some EMS people and just sort of talking about, a new triage system that you're going to be using in the region and how that's going to work for kids. You may discover that, with some of these, mass casualty triage systems that we actually have out there, that they're really not easy to use for kids. And especially if you then do a demonstration drill as sort of a follow-up to that, and you get a whole bunch of different age kids, and you sort of ask them, to simulate their injury and things like that, you might discover where the holes are. So I think they're really powerful to just sort of focus in on one small little thing, and then, sort of practice it in sort of context, and then take it and actually turn it into a real drill. I know some other people have mentioned that they've been part of airport drills, hazmat drills. Those airport drills are huge. We do them for our region. And, multiple hospitals present and so on. And, we've had the same thing that Sarita mentioned. We've had patients I had a father-daughter that were supposed to be together. And, you know, the first thing she said to me, she says, I need to come out of my character. She said, because I don't know where my dad is. It turns out he's at a totally different hospital than she was at. And she didn't know she was supposed to be where she got transported to the pediatric hospital. So it's just a really interesting thing to actually think about, you know, is really how to use these kinds of, how to use these sort of micro focus drills that sort of really go down to, you know, whether it's just one agency, if it's one department, and so on. It can really be very powerful, and communities can really use this. And I really like the idea of using the healthcare coalitions to sort of roll these out. Healthcare coalitions can actually be the host on a virtual platform, and they can have their different agencies sort of inputting at the same time, doing sort of different simultaneous functions that would actually be part of a real drill. Can be very helpful.
Yeah, Deanna, I think, you know, one of the things that can be, I think, daunting for somebody that's never done this before is, you know, we see the big, sexy, mass casualty, full-scale functional exercise when everyone has moulage and they're coming in. And we've done those, you know, I've participated in those many times, but a lot of times you don't really learn as much doing those as you do these really targeted exercises. So the last really large-scale, fully functional exercise that we did, mass casualty related, we had kind of spin-off tabletops with radiology, another one with blood bank, another one with laboratory. And I think those actually got us a lot more valuable information, even though they were definitely way less resource intensive, way easier to pull off. And so I think the key message is, like, don't be scared of throwing your hat in the ring to be an advocate for children for these drills. As Margo put in the chat, become an evaluator for the drills, be an advocate for children in these drills, but also don't be scared to go out there and do it. You know, we've all learned by doing, and we've obviously stumbled and made mistakes, but we've all learned from that. And we're here as, I think, you know, guidance into how to do these effectively and really with a minimal impact to your operations, especially when you look at what we're dealing with COVID. If I were to do a full-scale drill in my EC right now, you know, taking off COVID precautions or anything like that, where we can't have all these people huddled together, you know, we're full all the time. And so it would be a challenge to say, we're going to use part of the EC for this drill, but these tabletops can be extremely valuable as long as you get the right people in the room. And hopefully we've given you some guidance related to who those people are in this talk.
Yeah, Margo, you've actually got a good point about an evaluator. So when we have our drills, we actually and of the virtual drills, we've actually had just participated in one done by one of the RDHRSs up in Massachusetts, and they actually did a really nice job. They sort of had observers. So you could pop into different rooms and you could kind of observe what was going on and what the conversations were in the simulated environment. And when we've actually done our functional drills, we've actually had, we use all sorts of kids of all various ages. And we actually have, we use nursing students, dental students, medical students to sort of accompany each child for throughout the entire drill process. And we actually use them to sort of, they fill out sort of a observer or evaluator sort of tool that we send along with them. While they're sort of gives them sort of, other than just watching the kid and sort of being like their pseudo babysitter for the, 90-minute drill, they actually can sort of answer some questions along the way, capture some time stamps and things like that. So it's just another way to sort of use other people that involve. Plus it gives those students a chance to understand what it means to actually exercise and what their roles might actually be in a true disaster.